Welcome everybody. We will talk about the part 2 of ulcerative vesicular and bullous lesion. We will talk about the cytomegalovirus infection. What is the etiology and pathogenesis of this infection? About 60 to 70% of population may be exposed to such type of viruses. A primary infection of cytomegalovirus may be asymptomatic or may have infection uh, like mononucleus like disease infection. The manifestation of the infection is more severe in the immunocompromised patient compared to immunocompetent patient. It is the most common cause of pneumonia after the hematopoietic cell transplantation within the first 120 days after the transplantation. Once the cytomegalovirus is established, latency will be latency within the connective tissue cell, such as endothelium of blood vessel, mononuclear cell, and the white blood cells. Cytomegalovirus within the endothelial cell may be contribute or maybe lead to vascular inflammation, vascular occlusion, and the end organ damage of the affected organ. So, what is the mode of transmission of the cytomegalovirus? The mode of transmission through the infected white blood cell through an intimate contact with a blood product. In organ transplant recipient, cytomegalovirus donor organ lead to cytomegalovirus infection in the recipient patient. What is the clinical finding of primary cytomegalovirus infection? Infection resembling infectious mononucleosis with marked lymphocytosis. It is unlike the more common Epstein-Barr virus associated infection mononucleosis. There is fever but little lymphadenopathy or splenomegaly. Serious complications of cytomegalovirus include meningoencephalitis, myocarditis, and thrombocytopenia. Approximately 90% of patients with AIDS have circulating cytomegalovirus antibodies. In these patients, cytomegalovirus tend to involve eye, gastrointestinal tract, mucocutaneous site, mostly the perianal and perigenital. The oral manifestation of cytomegalovirus in the mouth in the immunocompromised patient tend to appear as a single large ulcer and less often a multiple ulcer. These are usually painful and may stay for weeks or months. May involve any site in the oral cavity. Up to one third of ulcer co-infected with other viruses, especially herpes simplex virus and varicella zoster virus. Also, they have reported occasionally mandibular osteomyelitis, tooth exfoliation associated with cytomegalovirus and varicella zoster virus. Both viruses associated with vesiculopathy and thrombosis, which may lead to uh, complication of this infection, and it is the most important etiopathogenesis of this type of infection. What is the management of the cytomegalovirus? Pain is managed with topical anesthesia and systemic analgesia sometimes. Also, appropriate dietary modification and good hydration is essential in this type of infection. Cytomegalovirus infection is treated with guncyclovir and volganciclovir, a new generation of viral therapy. Valcyclovir is a prodrug of guncyclovir and it is tenfold the bioavailability of the ganciclovir. It is more stronger the ganciclovir. This picture showing the ulcer in a background of hairy leukoplakia in patient with AIDS. Is there any vaccine for the cytomegalovirus? Yes. Cytomegalovirus vaccine is currently under development, so we can say it is in the embryonic stage. Now we will talk about the coccidiovirus infection. Coccidiovirus infection is a ribonucleic acid RNA virus. The most commonly type A, and some type B. 90% of infection caused by non-polio enteroviruses and either asymptomatic or result in non-specific febrile illness. The viruses replicate first in the mouth and then extensively in the lower GI tract where they shake. What is the transmission? Mode of transmission of this virus is primarily by the fecal oral route, although some shedding of the virus may occur in the upper respiratory. Coccidiovirus A infection is implicated in paralytic disease, which is a cold-like illness and upper respiratory tract infection that is usually a febrile and pleurogenia. What is pleurogenia? Is a sharp pain in the side, usually located in the intercostal muscle. Coccidiovirus B, particularly before infection, is associated with the development of aseptic meningitis, which is mostly complicated by encephalitis, carditis, and disseminated neonatal infection. It has been found that enteroviruses have been implicated in the pathogenesis of type 1 diabetes mellitus, which is insulin dependent diabetes. In the oral cavity, coccidiovirus infection lead to three disease entities. First, hand, foot, and mouth disease. Herpangina. 3. Lymphonodular pharyngitis. Hand, foot, mouth disease, as with any infection, viral infection including herpangina, tend to be seasonal, usually in the summer, occur in the epidemic cluster and has high transmission rate. Atypical hand, foot, and mouth disease show a widespread oral and skin involvement, and also there is a separation of nail plate from the nail bed and is caused by coccidiovirus A6. Oral finding is usually seen in children younger than 10 years of age in summer. Patient seen with low-grade fever, sore mouth. Patient develop skin rash, especially in the hand and feet, dorsal, palm, and sole. And 30% of patients seen with apotox skin rash. The rash is first red, then macular, and then become vesicular. Vesicular. Oral manifestation. Patients are febrile, complain of sore throat. Lesion begin as erythematous macule, then become vesicles, which quickly rupture down to form an ulcer. This mostly located in the tongue, hard and soft palate, buccal mucosa, may be seen in any oral mucosal the word herpangina derived from herpes, meaning vesicular eruption, and angina, meaning the inflammation of the throat. Herpangina is mostly related to serotype 1, 10, 16, and 20, 22. These are the most commonly isolated serotype of coccidiovirus A. Clinically, patients or children younger than 10 years of old are affected. The outbreak mostly epidemic in summer. Patient develop fever, headache, myalgia, and this may last for 1 to 3 days. Oral manifestation: the first oral symptom of herpangina, sore throat, pain on swallowing. There may be erythema of the oropharynx, soft palate, and tonsillar pillar. Later on, small vesicle form, rapidly break to form an ulcer, which is 2 to 4 millimeter in diameter. These persist for 5 to 10 days. Now we will talk about lymph nodular pharyngitis. Is considered a variant of herpangina and is associated with toxovirus A10. Patient also report a sore throat, but rather than presenting with vesicles that break down to form ulcer, patient develop a diffuse small nodules in the oropharynx. Laboratory test: the diagnosis is usually made on a clinical finding, and culture and biopsy are rarely necessary for the diagnosis because to the clinical finding and history from the patient is enough to develop the diagnosis. What is the management? It is, as any viral disease, it is self-limiting unless a complication arises in a patient with immunocompromised situation, and management is directly toward the control fever, mouth pain, supportive care, and limiting contact with others to prevent spread of infection. Effective antiviral agents for toxovirus are not available yet. Now we will talk about the necrotizing ulcerative gingivitis and periodontitis. It is acute ulcerative inflammatory condition of the gingiva and periodontium. It is called trench mouth because it is mostly associated or affected soldier in a trench, both with strong association with immune suppression, especially patients with AIDS, debilitating, smoking, stress, poor oral hygiene, local trauma, and contaminated food supply. Also, diabetes mellitus may be one of the risk factors associated with this condition. It is unclear whether the uh, necrotizing ulcerative gingivitis or periodontitis, often seen in patients with AIDS, but it is not unclear if it is the gingivitis uh, lead to periodontitis here. Both necrotizing ulcerative periodontitis and NOMA thrive in community characterized by large low socioeconomic classes and poverty. That means that this type of condition, which is necrotizing ulcerative periodontitis and gingivitis and NOMA, can be seen mostly in patients with low socioeconomic classes and poor. What is the etiology and pathogenesis? Treponema species were the most commonly seen associated with this condition. Also, there are other type of bacteria. Tissue destruction: gingiva and adjacent tissue is mostly associated with production of endotoxin and or immunological activation. Patients show reduced neutrophil chemotaxis and phagocytosis resulting from poor control of infection. In another word, that poor control of infection in such patients due to neutrophil chemotaxis and phagocytosis defect. There is a reduce in neutrophil chemotaxis and phagocytosis, so there is no control for the infection in this condition. Some cases identified herpes virus from the cervical fluid, but such viruses shed readily in the oral secretion, particularly where there is a tissue destruction. There, there may be association between necrotizing ulcerative gingivitis, periodontitis, and underlying systemic disease. May give rise to nome, orofacial gangrene, or cancrum oris. This is particularly devastating in children with malnourished and live in a poverty condition. It is not infrequent. It is not infrequently in Africa. So it is most commonly seen in Africa. Fusobacterium is play an important role in the progression of the necrotizing ulcer of periodontitis to cancrum oris or noma, because this organism produces dermonecrotic toxin, hemolysin, leukotoxin, and a proteolytic enzyme. All these material leading to extensive tissue. Clinical finding of necrotizing ulcerative gingivitis and periodontitis may or may not be associated with fever, malaise, and submandibular lymphadenopathy is usually present. The manifestation, as we said, it is acute and rapid onset of condition associated with excessive salivation, metallic taste, and sensitivity of the gingiva are the first symptom of the condition. Rapidly develop into extremely painful and erythematous gingiva with a scattered bunched out ulceration, usually affect the interdental papillae, and the marginal gingiva may be also affected. There is accompanying of malodor and gingival bleeding. Because of the pain associated with gingivitis, there is usually a build-up of dental plaque, large amount of plaque around the teeth. It may be too painful to perform effective oral hygiene. Risk factor for this condition: immunocompromised and neutropenic are prone to develop such. Patient with AIDS, the prevalence of necrotizing ulcerative periodontitis is 66%, and it is strongly predictive of CD4 count, which is less than 200 cells per cubic millimeter, leading to osteonecrosis or necrosis of the soft tissue. In patients who have severe immunodeficiency or malnourished, this condition progress to normal. The overlying skin become discolored, perforation will be occur later on. The orofacial lesion is a cone-like shape with the base of the cone within the oral cavity and the tip to the skin aspect. There is a sloughing of the oral mucosa, followed by sequestration of the exposed necrotic bone and teeth. Without a treatment, the mortality rate may be range from 70 to 90. This picture shows the necrotizing ulcerative gingivitis with a typical punched out necrotic and ulceration of the interdental papillae with bleeding gum. Management consists of gentle debridement to remove the debris and the plaque, and it is mostly done with using topical anesthesia during the first few visits. Using the chlorhexidine multiple lead to resolution of more than 90% of cases. Patients with extensive disease or other systemic symptoms require antibiotic active against the gram-negative anaerobic, such as beta-lactamase. It has been found that metronidazole effective in such condition. Once the acutely painful episodes resolve, scaling and route planning to remove completely the residual plaque calculus is indicated. Periodontal surgery may be necessary later on to correct the gingival and periodontal defect. It may be appropriate to test the patient for HIV or other immunosuppressive conditions such as blood dyscrasia when the patient having this type of condition. Cases of trauma need aggressive treatment with nutritional supplementation, antibiotic, and tissue. Now we will talk about erythema multiforme. It is an acute, self-limited inflammatory mucocutaneous disease manifestation in the skin, oral mucosa, although other mucosal surfaces may be affected, such as genitalia. It is a hypersensitivity reaction to infectious agent or medication. There is still controversy about how best to classify the erythema multiforme. It is classified into minor erythema multiforme minor if it is if there is less than 10% of skin involvement and there is minimal to no mucous membrane involvement. Erythema major, more extensive but still characteristic skin involvement with the oral mucosa and other mucous membrane affected. It is likely there is a likely a subset of erythema multiforme affecting the oral mucosa only without skin involvement. Historically, a severest form of erythema multiforme, labeled as Stephen Johnson syndrome and toxic epidermal necrolysis. But recently, it is an entity alone. It is not related to erythema multiforme, and we will talk about that later. Now, what is the clinical finding of erythema multiforme? It affects patients between 20 to 40 years of old, and 20 of children may be affected. Patients with recurrent erythema multiforme should have at least an average of 6 episodes a year, range from 2 to 24, with a mean of duration of 9.5 years. Remission occurred in 20% of cases. The episode usually lasts for several weeks. There may be prodrome of fever, malaise, headache, sore throat, rhinorrhea, and cough. These symptoms suggest a viral, mostly respiratory tract infection, and this is not surprising since the infectious agent trigger the erythema multiforme. Maybe herpes simplex virus, for example. Skin lesion appear rapidly over a few days and then followed by red macule that become papular, starting primary in the hand and moving centripetally toward the trunk in a symmetrical distribution. The most commonly affected site, upper extremities, face, neck. The lesion take several forms, therefore it is called erythema multiforme. The classic skin consists of a typical target or iris lesion that is pathognomic for the erythema multiforme. There is a variant which is atypical target lesion may be also seen. The skin may feel itchy and burn. Post-inflammatory hyperpigmentation is a common after the inflammation, mostly in dark-skinned individual, and may be worsened under the sun. Oral finding range from mild erythema and erosion to large painful ulceration. Severe large ulcer causing difficulty in eating, drinking, and swallowing. Patient in erythema multiforme draw blood stained saliva, extensive lymph involvement with inflammation, ulceration, crustation are most common. Oral lesion can be seen between 23 to 70% of patients with recurrent erythema multiforme. The common mostly affected sites, starting with the lips, buccal mucosa, tongue, labial mucosa, genital and ocular mucosa. Crustation and bleeding of the lip are common but not always present. This is the target iris of the skin, and this is the crustation, extensive involvement of the oral cavity of the lips, crustation of the lip, and this is how the labial mucosa, gingiva, and the lip affected. So, what is the etiology and pathogenesis of erythema multiforme? As we said, it is a hypersensitivity reaction. Most common factor affecting the patient in erythema multiforme: infection with herpes simplex virus, mycoplasma, and chlamydia pneumonia. A drug reaction to non-steroidal anti-inflammatory, anticonvulsant, other medication may play a smaller role. Cases of oral erythema multiforme may be precipitated by benzoic acid, food preservative, also reported. The study showed that recurrent erythema multiforme associated mostly with herpes simplex infection in about 70% of cases, both by history of herpes simplex infection 1 to 3 weeks before the onset of erythema multiforme. In another word, patients affected with herpes simplex virus infection after 1 or 3 weeks of the onset of the infection, recurrent erythema multiforme may be occur. So this type of erythema multiforme triggered by herpes simplex virus infection. It has been found that CD34 cell, Langerhans cell precursor, carry fragment of herpes simplex DNA to the skin where it initiated erythema multiforme. Management of patients with erythema multiforme: mild erythema multiforme may be managed with systemic or topical analgesia to support the pain. Also supportive care, since the disease is self-limiting and resolving within few weeks, no need for other treatment. But more severe cases, usually managed with systemic corticosteroid, topical steroid, may resolve the lesion. Cases suspected with herpes simplex associated erythema multiforme may be treated with antiviral medication. Treatment with acyclovir at the first sign of disease in recurrent erythema multiforme may control approximately half of cases. Other treatment modality may include dapsone, hydrochloroquine, azathioprine, colchicine, methotrexate, and intravenous immunoglobulin. Continuous acyclovir at 400 mg twice a day prevent development of erythema multiforme in patients with herpes simplex virus associated disease, where the erythema multiforme not related to herpes simplex respond well to azathioprine 100 to 150 mg per day. Other studies showed a good suppression of recurrent herpes simplex virus associated erythema multiforme using 500 mg of acyclovir twice a day or 25 mg of acyclovir twice a day. Also, studies showed that dapsone 100 to 150 mg per day anti-malarial medication are partially successful in suppressing the recurrent outbreak. But also, Now we will talk about Stevens-Johnson syndrome and toxic epidermal necrolysis. Studies done within the last 10 to 15 years support the concept that Stevens-Johnson syndrome is a least severe variant of toxic epidermal necrolysis, and it is separated clinically and etiopathogenetically from the erythema multiforme. Although three of them are hypersensitivity reaction and give rise to oral fully erosion ulcer and crusted lip. The skin lesion of Steven Johnson and toxic epidermal are different from erythema multiforme. They are more severe and tend to arise on the chest rather than the extremities on the erythematous and Berberic macule. These lesions are called atypical targets. Stevens-Johnson syndrome is much more likely to be associated with medication used and mycoplasma pneumonia infection, especially in children, and rarely with herpes simplex virus infection, whereas erythema multiforme is much more likely to be associated with herpes simplex virus infection. Some cases of mycoplasma pneumonia associated with erythema multiforme, the more common associated drug include antibacterial sulfonamide, penicillin, anticonvulsant, and non-steroidal anti-inflammatory medication in children, and allopurinol, oxycam, and nevirapine in the adult. Developing of Stevens-Johnson syndrome and toxic epidermal necrolysis to the aromatic anticonvulsant carbamazepam and phenytoin may also be associated. The mucosal surface of eye, genitalia, mouth are most always severely affected by both of Stevens-Johnson's and toxic TNE, always with skin involvement. The typical oral manifestation is extensive oral ulceration, hemorrhagic crust, and on the vermilion and other oral mucosal surfaces. Histopathologically, most of the disease is located in the epidermis and where the drug site is or its metabolite is bound with less inflammation in the dermis. Because of the severity of this condition, treatment is generally with intensive supportive care because of loss of skin barrier, intravenous immunoglobulin, systemic steroid, cyclosporine, and other type of medications of tumor necrosis factor alpha because the disease is extended. Now we will talk about plasma cell stomatitis and oral hypersensitivity reactions. Talking about etiology and pathogenesis, considering the oral hypersensitivity reaction in the oral cavity, there are 6 forms. First of all, acute onset of ulcer such as in erythema multiforme, red and white reticulated lesion of lichenoid hypersensitivity reaction, 3 fixed drug eruption, marked erosion and erythema especially on the gingiva with or without ulceration called plasma cell stomatitis, swelling of the lips, angioedema, oral allergy syndrome that present mainly with symptom of itching with or without swelling of the oral structure and oropharynx. Plasma cell stomatitis is a hypersensitivity reaction that was first described in 1960 and early 1970. Was likely a contact stomatitis to a component of chewing gum. Since then, cases have continued to be reported, and these are all likely caused by sensitizing contactant, where or not the contactant is identified. These may include gut, component of toothpaste, mint candies, and household cleaners. Because of the intense plasma cell infiltration, it is believed that it is B cell mediated disorder with T cell augmenting the response. Some believe that this is caused by component of blood bacteria, although this is not a universally accepted concept. So this picture showed the plasma cell gingivitis. So it is a general gingivitis, upper and lower uh, gingiva. So what is the oral finding? Within days of exposure to the contactant, with the most sign and symptom limited to the oral cavity, some lesion may affect peri-orofacial tissue or oropharynx, leading to upper airway symptom of hoarseness of the voice, dysphagia, and mild airway obstruction. Endoscopy may reveal erythematous thickened mucosa, often with cobblestone appearance from the oedema. An obvious allergen content is not always ideal. Oral manifestation, as we said, it will appear within a few days after the exposure. Erythematous macular area of oral cavity involving marginal and attached gingiva, alveolar mucosa. Soft tissue may also be affected in the maxillary and mandibular sulcus, buccal mucosa. Ulcer may be or may not be present. Epithelial sloughing and desquamation may be also seen. The gingiva may be swollen and edematous. Patient feel pain and sensitivity, bleeding of the gingiva on brushing. Angular cheilitis with fissuring and dry atrophic lips have been also reported. Some cases of plasma cell stomatitis consisted of a very localized area of erythematous gingiva, usually around a single tooth and measuring usually less than 1 centimeter. Laboratory finding: patch testing to identify an allergen may be helpful. A biopsy is the most helpful diagnosis test for this condition. A biopsy for the gingiva in plasma cell stomatitis show parakeratosis, epithelial hyperplasia, neutrophil, and numerous spongiotic pustule in the absence of candida. The most significant finding is a dense sheet of plasma cell in the lamina propria, many dilated capillaries close to the surface, accounting for the marked erythemia. Eosinophils are not seen usually. Immunodeoxidase stain will invariably show the plasma cell infiltrate to the polyphenol, typical reactive of inflammation. So, because there is a dense sheet of a plasma cell, it is called the. Now we will talk about the management of basal cell plasma cell stomatitis. Although it is self-limited and it is generally but not always rigorous if the contactant is identified and then removed. Pain control and anti-inflammatory agent may be helpful during the course of healing process. Topical steroid help to reduce the inflammation and speed the healing. Some lesions need intralesional triamcinolone injection, intralesional steroid, although the gingiva is a difficult location for such intralesional injection. Cases may respond well to prednisolone. Gingivectomies may be needed to recontour the lesion after long standing of inflammation and fibrotic gingiva. Also, it has been found that 2% of fusidic acid may improve some cases of plasma cell stomatitis.